Hello, my name is Ray Chaudhuri. I'm a non-motor man, but I'm very surprised I've been asked to talk on dyskinesias and particularly this evocative issue as to whether non-troublesome dyskinesias should be treated. My position, it should not be. Please note, I'm talking about non-troublesome dyskinesias. And this is what I call the elephant in the room. I would probably call it elephants in the room, because the concept of what is troublesome versus non-troublesome remains very, very vague indeed, in my view. Of course, please remember, I'm a non-motor man. And this particular debate has come from a war of academia, which was set off by our first viewpoint article. Should there be less emphasis on levodopa-induced dyskinesias? This upset a lot of people who do a lot of dyskinesia research. So we had an angry riposte, of which my opposition member or oppositionist member of, he said, and they said, dyskinesia matters. We responded by saying dyskinesia matters, but not as much as it used to. And I'll come to why in a minute and how this links to non-troublesome dyskinesias. Firstly, what is troublesome dyskinesia? Well, they are disabling. They can render a patient household who might become unable to mobilize without a caregiver, diminishes quality of life. This is absolutely true and is in fact endorsed by my esteemed opposition member. But if we are modern, and if we have modern treatment, a judicious use of levodopa, which everybody propagates, continuous drug delivery, about which you hear in every meeting, the fantastic success of deep brain stimulation-related subthalamic nucleus DBS, we shouldn't be really causing troublesome dyskinesias, right? Okay, if we're not causing troublesome dyskinesia, what should we treat? We should really treat the unmet needs, right? Shall we ask patients, what do our patients think? And those unmet needs are not just non-troublesome dyskinesias. So here is a survey report. Oops, I've gone back. Now I should go next. Which looked at over 173 patients. And I think patients are all over all over the world. And you can see amongst their top 10, dyskinesia does not feature. Response to fluctuating response features, which is largely off-related issues. Amongst 7 out of the top 10 are non-motor. This is what our patients are telling us. So shall we still spend our resources and our efforts in the clinic treating non-troublesome dyskinesia? This is a question I ask you, and a question asked to my esteemed opposition. Let's look at some data. Scott et al. Showing that in their community-based incident cohort, only 15% required a treatment change, and only 10% found dyskinesias to be mildly disturbing. Another study from Bjornstedt et al. Showed in a population-based longitudinal study that less than 1% rated their dyskinesia as severe, and less than 2% as painful. Let's look at more recent data from 2 independent cohorts in the United States and in Brazil, reported mild or even no impact of dyskinesias from their cohorts. If you still don't believe it, let's go to our opposition. Professor Power and colleague in their cohort reported in a phase 2 ADS 5102 clinical trial cohort that the severe impact on activities of daily living by dyskinesia was less than 5%. Moderate impact was only in less than 30%, and the majority reported mild or even no impact from dyskinesia. So I think my opposition member is now advocating treatment for the majority who report mild or even no impact from dyskinesia, because that's what we would call what non-troublesome dyskinesia is. Okay, let's now see what are we going to manage them with. Let's see, my opposition is saying we're seeing a motor phenomenon of no major consequence to the patient as per a wealth of studies I've shown and patient views. Let's see what is he going to propose treatment with. 2 recent reviews, one from our group, Letta et al., and the others from Susan Fox, the esteemed MDS task force. Only levodopa infusion, amantadine, clozapine, bilateral DBS, and unilateral pallidotomy are efficacious in treating dyskinesia. So is my opposition member saying now non-troublesome dyskinesia, which has no or hardly any effect on our patients, will be treated by levodopa infusion, clozapine, TBS, either GPI or STN, or unilateral pallidotomy? The mind boggles. Let's now go into some another factual consideration. You'll all be familiar with the PD Med study, published in Lancet. Some people like it, some don't. But what does it tell us? That in the long term, it doesn't matter. You can see 7 years follow-up data that levodopa and levodopa sparing strategy focusing on dyskinesia reduction. You can see the dyskinesias develop more or less in even pattern or remain even between the two groups at 7 years. So it doesn't really matter. And secondly, if you treat a patient with any of these non-dopaminergic agents for their dyskinesias, for their non-troublesome dyskinesia, the likelihood that they will be stopping the treatment. Here's the rate of fallout with dopamine agonists, with MAO-B inhibitors at 7 years. You compare that with only 7% with levodopa. So whatever you try to treat this non-troublesome dyskinesias with, it's not going to last, I'm afraid. Patients are going to come off it as per the PD Med study. Let's look at another aspect of it. In response to our last academic war, another response came from the same group of which Professor Power is a member of. Reply to the letter, as you can see. And what they say, a highly effective, well-tolerated anti-dyskinesia therapy would afford us the opportunity to use levodopa more liberally to improve patients' motor function and quality of life. Sad fact is, we don't have it. Do we? Well, let's look. Here is the search for preclinical and clinical reduction in dyskinesias. The search, I'm afraid, is continuing. These are examples of recent licensed or to-be licensed medications optimizing the effect of levodopa, novel formulations in a quest to reduce dyskinesia. And if you're in the research field, you'll be very excited by a list, a plethora of studies over the last 10 years, all addressing treatment of dyskinesias. So my second question is, if you are going to treat this non-troublesome dyskinesia, my esteemed colleague, what are you going to treat them with, which gives you relative safety, efficacy, and peace of mind? Why is this important? Because an undue focus on non-troublesome dyskinesia might neglect some key health issues. Do we have example for this? Yes, we do. Here's a patient. Look at the blue square first. The patient is actually untroubled by dyskinesias, does have non-troublesome mild dyskinesias. Onynia stage is 3. The patient is severely anxious about any off periods. My esteemed neurology colleague, who shares the view of my opposition today, added amantadine. A diary was kept of dyskinesias. At 1 month, this patient was ringing our nurse specialist who had severe hallucinations, ankle swelling, and sleep dysfunction. The patient then represents, and the nurse specialist, and absolutely bless our nurse specialist, does a non-motor symptoms questionnaire. Takes 2 minutes, patient completes it. In the NMS quest, the same patient completes and scores 17, has a severe burden of non-motor symptoms. And this particular doctor, instead of managing or creating pathway for swallowing problem, dribbling of saliva, constipation, REM behavior disorder, restless leg syndrome, and anxiety, only treated the non-troublesome dyskinesia. You would all agree that that's not ideal, right? Let's now come to another issue which is listed in the book written by my opposition, Professor Power. Beautiful book it is. Another problem here with amantadine, for instance, libido reticularis. Amantadine has been also been known with sleep dysfunction, as well as, in some cases, confusional problems, and of course, hallucination, as you saw in the previous case. Clozapine, well, you can think about, do you want to put a patient on weekly blood monitoring for a non-troublesome dyskinesia with a risk that this particular drug can cause agranulocytosis? Are you being serious? So finally, I would just like to Rest the case, therefore, ladies and gentlemen, that specific treatment of non-troublesome, non-intrusive dyskinesia is needless, unless it's part of a routine drug management. Of course, we all do that. There are also no convincing studies, in my view, which will suggest if somebody has non-troublesome dyskinesia, you don't treat that, that particular dyskinesia will evolve to troublesome dyskinesia. And in my view, such overzealous management would do what? Three things. First, expose the patient to needless side effects of oral drugs, amantadine, clozapine, for instance. The agents would likely to be discontinued in the long term, as PD-Med shows. And finally, it'll increase the cost of care, an increasingly value-driven market that healthcare is now based on, and might, more importantly, management could focus on key non-motor symptoms, which might be left untreated if the focus remains on non-troublesome dyskinesias. I would like to end by another slide. The elephant comes back. So here we have a head-to-head dyskinesia versus other unmet needs. In my view, first address the troublesome unmet needs, then you might want to address the non-troublesome dyskinesia. And finally, we need to listen to our patients. And here they are. Thank you very much.